Now we'll discuss one MCQ. A trained athlete undergoes progressively increasing treadmill exercise. During the initial moderate phase, arterial PCO2, PO2 and pH remain nearly normal despite marked increase in oxygen consumption and carbon dioxide production. Later, during severe exercise, sustained exercise, blood lactate accumulates, arterial pH falls to 7.2 and arterial PCO2 decreases significantly. Which of the following best explains the fall in arterial PCO2 during severe exercise? Reduced metabolic carbon dioxide production due to muscle fatigue, failure of peripheral chemoreceptors during acidosis, ventilation increases disproportionately more than carbon dioxide production because of metabolic acidosis. Here the answer is C. So let us discuss why this answer is C and why not other options. During mild and moderate exercise, the arterial PCO2 and PO2, the production of arterial PCO2 from the skeletal muscles or metabolic demand will exactly matches with the pulmonary ventilation or PO2 utilization. This is called as isocapnic buffering. This phenomena is called as isocapnic buffering. In mild and moderate exercises, the arterial PCO2 production and the oxygen utilization is exactly matches with the metabolic demand. But in severe exercise, what exactly happens? In case of severe exercise, the arterial PCO2 production is out of proportion of oxygen utilization. So what will result if the arterial PCO2 is more than oxygen utilization? It further increases pulmonary ventilation. So if it further increases for more pulmonary ventilation, then what will happen? It results in alkalosis due to PCO2 will decrease after severe exercise. So here one note to down that during the initial exercise, when we start exercise initially, when we start exercise initially, the arterial PCO2 will be increased, or the work done by the muscles will be increased due to increased proprioception from tendons. So this is due to psychic stimuli from the proprioceptors from the tendons that causes increased work done by the muscles, that causes increased arterial PCO2 initially. So initially the arterial PCO2 is due to this. Later on, during mild and moderate exercise, work done will be equivalent to the oxygen utilization, and in severe exercises the arterial PCO2 is out of proportion of pulmonary ventilation or oxygen utilization. So let us discuss, coming back to the MCQ, let us discuss the options. Reduced metabolic carbon dioxide production due to muscle fatigue. Here the metabolic carbon dioxide production is not reduced, the metabolic carbon dioxide production will be more. So this option is not correct. Failure of peripheral chemoreceptors to during acidosis, the peripheral chemoreceptors to acids K plus and CO2 is still intact. So this option is not correct. Ventilation increases disproportionately more than carbon dioxide production because of metabolic acidosis. This option is correct. Here the PCO2 is more than PO2 utilization. The production of PCO2 will be more than PO2 utilization, pulmonary ventilation, as discussed here. Coming to the option D, increased pulmonary dead space reduces effective alveolar ventilation. This option is not correct. Alveolar ventilation does not depend upon the pulmonary dead space. Rather, the alveolar ventilation is dependent upon the respiratory rate and PCO2. So, this option is not correct. Central respiratory center depression caused by lactic acid. No, this option is not correct. The central respiratory center depression or stimulation dependent upon the PCO2 and H plus ion arterial. So, it is rather if the acids will be stimulated the central respiratory center, not depression. So, here the correct answer is option C.